Good evening to everyone. This session will be a case discussion on an oral cavity carcinoma, which is, a part and parcel of your super specialty practical exams, right? So, uh, we have already discussed this, on the drug oncology group. Unfortunately, that recording was not preserved, so I'm redoing the case presentation. These are the slides shared with me by Dr. Sriram, so I thank him for that. Now, moving on, let us look at all the different components in the history and examination if you get a case of CA oral cavity, right? So first I'll present the history. So you have a patient who's 63 years old, who's male, who's a bakery worker by occupation from Kerala. He presents with an ulcer in the left side of the tongue since 2 months and pain in the left side of the tongue since 1 month. So the patient was normal 2 months back when he noticed an ulcer in the left side of the tongue, which is initially 1 centimeter in size and gradually increased over a period of the last 2 months to 4 centimeters. And since the last 1 month, he complains of pain, which is dull aching, moderate in intensity, and it is aggravated when he has food and is relieved on medications. There's occasional associated pain in the left ear since past 1 month. There's history of excessive salivation. There's no history of difficulty in mouth opening. There's no history of difficulty in moving of the tongue. There's no history of difficulty in swallowing food or painful swallowing. There's no history of bleeding from the ulcer, hoarseness of voice, or loosening of teeth. And there's no history of any swelling or ulcers elsewhere in the oral cavity. And there's no history of neck swellings as well. No history of breathlessness, cough or hematitis, loss of weight or appetite. Past history, there are no comorbidities, no known comorbidities in this patient, no history of similar complaints in the past, no history of previous surgeries, and no history of any other malignancies. Personal history, he's a chronic smoker with a 30-pack-year history. He's non-alcoholic, does not consume tobacco in any other form, right? And he has normal bowel, bladder, and sleep habits. Family history, there's no history of similar illness in the family or of any other malignancies in the family. So to summarize, we have a 63-year-old male who's a chronic smoker who has presented to us with complaints of painful ulcer of the left half of the tongue since 2 months. And so based on this history, what is the differential diagnosis, right? So there's a ulcer which has developed over the lateral half of the tongue since 2 months, and it is associated with pain and referred pain to the ear. So what is the DD? So we'll come to the DD. Before that, let us look at the history and look at what all can be asked when it comes to your history, right? So the most common oral cavity cancer that is seen worldwide is CA tongue. The most common oral cavity cancer seen in India, the Indian subcontinent, is buccal mucosa cancers, right? Now, let us start from the beginning. What is the significance of age in head and neck cancers, right? So you have generally head and neck cancers occur in middle-aged patients, in the 50s and 60s, with an extensive history of tobacco intake in various forms. But there are certain head and neck cancers that can occur at a younger age. For example, nasopharyngeal cancers have a bimodal distribution. They can occur in the 20s and 30s as well as in middle-aged patients, right? Then your salivary gland tumors, they can occur in younger ages, such as the second and third decade. Also, you have HPV positive oropharyngeal carcinomas, which also occur at a younger age, so in the fourth decade or so. So those are some of the cancers that occur at the younger age. Now, what is the importance of age in this setting? There are certain head and neck cancers where the staging depends on the age. So an example of that is thyroid cancer, where 55 is the cutoff, uh, and it has prognostic and staging implications when it comes to thyroid cancer. So age is important in that way as well. Now, coming to sex, thyroid cancers are more prevalent in female patients. So that is an important head and neck cancer where sex plays a role. And coming to occupation, of course, patients with increased radiation exposure are at an increased risk of head and neck cancers, for example, thyroid cancers. Also, patients with, who do woodwork, or carpenters, those patients are at an increased risk of sinonasal carcinomas. So that's the importance of occupation in head and neck malignancies. Now, before we get into this, let's look at the incidence of oral cavity cancers worldwide. This is something that can be asked. So worldwide, it's only the 16th most common carcinoma as per Globocan 2022. But in India, it is the second most common cancer overall, with an incidence of 26.3 per 1 lakh patients. And in case of males, it is the most common malignancy. So that is the the vast disparity um, when you compare oral cavity malignancies between India and the world, right? So second most common overall in India and most common in males. Now let us go over these chief complaints, right? So you have an ulcer on the left side of the tongue, and it is associated with pain. So what are the implications of pain in an oral cavity cancer? So this could mean ulceration and associated inflammation. If there is an infiltration of the nerves, especially the sensory nerves, for example, in the tongue, it is the facial nerve, the trigeminal nerve. If they're involved, it can also cause pain. Then, of course, there's a concept of referred pain, which we'll touch upon later, especially to the ear when various parts of the head and neck are involved with malignancy. And of course, it can be a harbinger of advanced disease, right? So if there's bony invasion, if there's extensive muscle invasion and destruction, it can also cause pain. So those are the causes of pain. Now, we spoke about there's no history of difficulty in mouth opening, right? That is also called trismus. So what are the causes for difficulty in mouth opening in a head and neck cancer patient? You need to know them off the top of your head. So, of course, pain can also lead to decreased mouth opening, but you can also get it in oral submucous fibrosis, which is seen with areca nut consumption, right? And betel leaf consumption. Then, of course, this can also imply that the disease is advanced. So if there's involvement of the lateral pterygoids, the digastric muscles, the temporomandibular joint, or the masticator space. The masticator space consists of the masseter muscle, the temporalis muscle, and the medial and lateral pterygoids. So if these structures are involved, if the disease is advanced, there also you can get difficulty in mouth opening. Now, what are some of the grading systems for difficulty in mouth opening? So you have the CTCA version 5, which is graded as 1, 2, and 3. And so all three grades have difficulty in range of motion of opening the jaw. But the difference lies in that grade 1, the patient will consume orally. Grade 2, the patient has difficulty in taking solid foods and can only take liquid and semi-solid diet. And grade 3, the patient is unable to take orally, right? So then you have other, gradings based on the difference in the distance between the incisor teeth, right? So the mid-incisoral distance. So based on that, grade 1, grade 1 is greater than, so normal is greater than 35 millimeters. Then you have got grade 1, which is 26 to 35, grade 2, which is 15 to 25, and less than that is considered to be grade 3, right? So that's the grading as well. And most commonly, you can also use the 3-finger test to see the degree of trismus, where 3 fingers normally fit in. And if anything less than that, there is a degree of trismus involved. So those are the how you measure trismus. Now, what are the implications of degree of mouth opening? Right? Of course, like we said, it could be a harbinger of advanced disease. So the stage can be upstaged if there's trismus. There's a possibility for that. Although it is the other causes such as submucosal fibrosis and pain, it could mean an advanced disease state, right? Apart from that, it also has implications in terms of nutrition of the patient. So a patient with trismus will have decreased oral intake and you need to give nutritional support, right? So that can have implications for the management, the tolerance of the patient to treatment. So that is why you need to note down the degree of trismus and address it accordingly in terms of nutrition. Now, what is a third and most important thing here is that the surgical approach, right? So if the patient has severe trismus, it might be difficult to resect the tumor transorally. So there you might have to approach it through the mandible. So you might have to do a mandibulotomy, right? So the surgical approach is also decided by the degree of trismus. So that is why trismus is important. The stage, right? Nutritional needs of the patient, as well as the surgical approach. So those are some of the important implications of degree of trismus. Now, coming next to the degree of tongue movement, right? So that is also important because tongue movement might be restricted if there is involvement of the floor of the mouth, right, below the tongue, or if there's involvement of the extrinsic muscles of the tongue, which help in tongue movement, right? So the palatoglossus, the genioglossus, etc. Also, if the hypoglossal nerve is involved, which is the major motor nerve, influencing tongue movement, there also you can have decreased tongue movement. So those are some of the causes of decreased tongue movement that they can ask you. Now, before we get further down the road, let us look at this patient has referred pain, right? And it is an examiner's favorite question. What are the causes of referred pain in a head and neck malignancy? So you need to be aware of various different pathways. So if the glossopharyngeal nerve is involved, right, it can be involved in a case of oropharyngeal malignancy and posterior one-third of the tongue. So oropharyngeal malignancies and posterior one-third of the tongue, the glossopharyngeal nerve can be involved. That can lead to referred pain. Then if the larynx or hypopharynx is involved through the Arnold's nerve, which is a branch of the vagus nerve, this can also lead to otalgia. So that is in case of larynx or hypopharynx. Now, coming to the involvement of the trigeminal nerve, the branches of the trigeminal nerve can, when they're involved, can also lead to otalgia. So what are the branches? So the lingual nerve in the case of anterior two-thirds of the tongue, if that is involved, that can lead to otalgia, right? And if the inferior alveolar nerve, which is a branch of the trigeminal nerve, if that is involved, especially in buccal mucosa cancers, that can also lead to otalgia. So these are some of the common pathways of otalgia that are, it's very commonly asked, right? Now, at this point, the examiner might also ask you the nerve supply of a CA tongue case, right? So the nerve supply of tongue is very important. So it is divided into motor and sensory. In motor, you have intrinsic muscles and extrinsic muscles. So the intrinsic muscles include longitudinal muscles and transverse muscles. These are supplied by the hypoglossal nerve, which is the 12th cranial nerve. The extrinsic muscles include the genioglossus, the hyloglossus, and the styloglossus. So all these three are supplied once again by the hypoglossal nerve, which is the 12th nerve, except for the palatoglossal muscle, which is supplied by the 10th cranial nerve. Now, coming to the sensory innervation, the anterior two-thirds is by the 5th and 7th cranial nerves, whereas the posterior one-third is by the 9th and 10th cranial nerve. So this is the nerve innervation of the tongue, which can commonly be asked to you, right? Now, moving on, let us look at difficulty in swallowing and painful swallowing. So you have difficulty in swallowing if anywhere along the pharynx you have a lesion, right? So if you have a lesion in the oropharynx, that can lead to difficulty in swallowing and odynophagia. If you have it further down in the hypopharynx or the larynx extending to the hypopharynx, also you can have difficulty in swallowing, right? So those are some of the causes for difficulty in swallowing and painful swallowing, which is not seen in this patient, right? Because it is a tongue lesion. Now, you have history of bleeding from the ulcer, right? So in a head and neck malignancy, what are the implications of bleeding? So that can happen if you have ulceration, like, severe ulceration can lead to bleeding. If the tumor is extending into nearby blood vessels, or the tumor itself is very vascular, that can also lead to bleeding, right? If you have other oral pathologies that you commonly see in head and neck malignancies, like, poor dental hygiene leading to gingivitis, that can also lead to bleeding, right? So those are the causes of bleeding that you see upfront, okay? Now, history of hoarseness of voice, right? So change in voice is most commonly seen in laryngeal malignancies, especially if you have glottic involvement that can present very early on with change in voice, or you can have a supraglottic lesion extending into the glottis, or you can have a hypopharyngeal lesion extending into the glottis, leading to fixation of the larynx. That can also lead to hoarseness of voice. You also have thyroid malignancies that can press on the recurrent laryngeal nerve and lead to hoarseness of voice. So these are the causes for hoarseness of voice that they can ask to you. Now, this is very important, this negative history. No history of any swelling or ulcers seen elsewhere in the oral cavity. So what are the implications of that? Now, at this point, they'll ask you, what is field cancerization? So when the carcinogen is exposed to an extensive area, right? For example, when you smoke tobacco, all the carcinogens in tobacco product, they travel throughout the entire aerodigestive tract, and the entire aerodigestive tract's mucosa is exposed to this carcinogen. So that can lead to various levels of pre-malignant lesions throughout the aerodigestive tract, right? That is called field cancerization. Other examples of field cancerization at different sites include exposure of the bladder to benzenes and other chemical carcinogens, or for example, exposure of the sun, exposing the skin to sun, which can lead to skin malignancies anywhere throughout the skin, right? So those are other examples of field cancerization. Now, at this point, they'll ask you, what is a synchronous malignancy and what is a metachronous malignancy? So synchronous malignancy is separate malignancy in the aerodigestive tract in the context of oral cavity carcinomas, a separate malignancy in the aerodigestive tract that is seen at the same time as the other malignancy, the primary malignancy. So if there's a second primary malignancy diagnosed in the aerodigestive tract at the same time, that could be a synchronous malignancy. Also, if you can if that develops within 6 months of diagnosis of the first primary, that is also considered synchronous primary, right? So metachronous is if the second primary malignancy occurs greater than 6 months after diagnosis of the first primary malignancy. So that is very commonly seen. There's a 1 to 5% chance of synchronous malignancies with head and neck malignancies, especially with tobacco intake. And there's a 20% chance of developing a metachronous malignancy later on, right? So 1 to 5% chance of synchronous and 20% chance of metachronous. So this is something that they will ask you. Now, there is something called the Warren and Grace criteria for a secondary primary, right? You need to be aware of that. So what are the criteria here? So the criteria include presence of two separate malignancies that have been histologically proven. There should be an area of normal mucosa between both the malignancies. The distance is considered to be greater than 2 centimeters or more. And third is that you should be able to prove that the second malignancy is not metastasis from the first malignancy. So these three criteria come under the Warren and Gates criteria for a second primary, right? So that is also something they'll ask you when it comes to head and neck tumors, which have high rates of field cancerization with tobacco consumption. Now, history of neck swellings, right? So history of neck swellings, some head and neck malignancies present with neck swellings rather than, with the primary leading to the diagnosis. So head and neck malignancies that present with neck swellings include nasopharyngeal malignancies, oropharyngeal malignancies, especially oropharyngeal malignancies that have, HPV positivity. So there you have a small primary and a large neck node mass. So there also can present with neck swelling. So these are the two types of malignancies. Also, you can say pyriform fossa malignancies also present with neck nodes, right? So those are the malignancies that present with a history of neck swelling. So that is also something that they can ask you. Okay. So of course, these head and neck malignancies, especially that of the oral cavity, oropharynx, hypopharynx, and larynx, these tend to metastasize commonly to the lung. So you need to rule that out in your negative history. Now, coming to the past history, right? An important question that they can ask you over here is the involvement of precursor lesions, right? Head and neck malignancies, especially oral cavity malignancies, have a variety of precursor lesions that can, you know, a variety of precursor lesions that can progress to malignancy. So let us look at some of these precursor lesions. The WHO classifies precursor lesions as precancerous lesions and precancerous conditions. So what is a precancerous lesion? A precancerous lesion is a morphologically altered tissue in which cancer is more likely to occur than its normal counterpart. Okay, I hope you got all those points. And a precancerous condition is a generalized state associated with significantly increased risk of cancer. So what are the precancerous lesions? So we have leukoplakia, which tends to occur in the oral cavity as a whitish patch. And based on the degree of dysplasia and leukoplakia, you have a 1 to 10% chance of transformation to malignancy. The second precancerous lesion is erythroplakia, in which there is a 15 to up to 50% chance of transformation to malignancy, right? There you see a reddish erythematous patch, and there's a higher chance than leukoplakia to transform to malignancy. You also have intraepithelial carcinoma in situ and palatal lesion of reverse smoking. So that's where they reverse the cigarette and use it. So that's also a precancerous lesion. Now, coming to the pre-malignant conditions, right? As classified by the WHO, when they ask you that, it is oral submucosal fibrosis, lichen planus, sideropenic dysphagia, xeroderma pigmentosa, and epidermolysis bullosa. So these are some of the pre-malignant conditions as classified by the WHO. So you need to be aware of all of these because that can, if the patient gives a history of that or if the patient has undergone a surgical procedure to remove such a lesion, you need to be aware of that. And that can be elucidated in the past history. Now, coming to the personal history, especially here in this particular patient, we can see over here that the patient has got a history of taking pack years of more than 30 years, right? So that puts him at an increased risk of developing malignancies of the aerodigestive tract. So here they'll ask you the definition of smokers, various types of smokers. So you have a never smoker, where the patient has smoked less than 100 cigarettes in their lifetime and no current cigarette use is seen. You have a former smoker, where at least 100 cigarettes were consumed in their lifetime and they have quit for more than 1 or more years. You have a recent smoker, where they've consumed more than 100 cigarettes in their lifetime and they've quitted, for at least 1 week back to 1 year back, right? So less than 1 year to 1 week, they've quit and they've smoked more than 100 cigarettes is a recent smoker. A current smoker is someone who actively smokes 1 or more cigarettes every day or every other day, right? So that's all called a current smoker. So you need to be aware of these terms. They can ask you that. Now, you also need to be aware of the contents of tobacco, the carcinogens that are seen in a tobacco product, right? So these include nicotine, right, which is an addictive substance. It includes N-nitrosamines. It includes polycyclic aromatic hydrocarbons. It includes, free radical substances, aromatic amines, acrolein. You have benzene. You have metals like nickel and cadmium, and you have radioactive materials like polonium 210 and lead 210. So these are some of the carcinogenic substances in tobacco. Now, what are the malignancies caused by tobacco? This can also be asked. There are 14 types. So you have lung, you have oral cavity and pharynx, you have esophagus, stomach, colon and rectum, liver, pancreas, larynx. You have the kidney and renal pelvis. You have the urinary bladder. You have the prostate, cervix, and one hematological malignancy, which is AML. So all these are caused by cigarette smoking, right? By using tobacco products. Now, moving on. So now we have, looked at the past and personal history. We have looked at tobacco. We looked at pre-malignant lesions. What about infections that lead to head and neck cancers? So you have predominantly two. You have HPV and EBV. EBV is seen in nasopharyngeal carcinomas, and HPV is seen predominantly in oropharyngeal carcinomas, and to a lesser degree, oral cavity lesions. Okay, so that is also something that you need to be aware of. So once you summarize this case, this based on the small history, based on the presence of ulceration and referred pain to the ear, and you can, and based on the history of cigarette smoking, you can consider a diagnosis of malignancy of the oral tongue, possibly a carcinoma. Now, what are the other non-malignant causes? Although you shouldn't say this in the exam, if the examiner prods you, you can say TB and syphilis of the tongue, which, although these are very rare lesions, but these are some of the non-malignant causes. Now, another site, apart from CA tongue, buccal mucosal cancers are also very commonly asked in your exams. So that can be another case that is kept, tongue or buccal mucosa. So if you were to get a buccal mucosa case, what would be your DDs, your malignant differentials? So buccal mucosa or alveolus is involved. These are your DDs. So number one will be carcinoma. Then you can have osteosarcoma of the buccal mucosa or alveolus. You can have rhabdomyosarcoma. You can have lymphomas, especially high-grade lymphomas like DLBCL and Burkitt's. You can also have plasmacytoma, or you can have metastasis to these structures. So these are some of the DDs if you get a case of buccal mucosa as your oral cavity case, right? Lovely. So general physical examination, we'll come to the examination part now. I think we have discussed all the various features that can be asked in a case of oral cavity cancer. So coming to the general examination, the patient is conscious and cooperative and well-oriented. Vitals are stable. There's no pallor icterus, generalized lymphadenopathy, or pedal edema. Now, coming to the local examination of a head and neck case, right? So we're going to start off with inspection. The skin over the face is normal. There's no facial asymmetry. The lips are normal. Mouth opening is reduced, so you have grade 2 trismus. Oral hygiene is poor. There's no oral submucosal fibrosis. Halitosis is present. There's no missing teeth, sharp teeth, or ill-fitting dentures. And tongue protrusion is normal, and there's no fasciculation. So there's a single ulceroproliferative lesion present in the left lateral border of the tongue, which is size 5 into 4 centimeter. It is approximately 1 centimeter from the tip of the tongue, extending from the left lower canine to the left second premolar. The lesion is 1 centimeter away from the circumvallate papillae. The margins are irregular, the edge of the ulcer is everted, and there's some slough on the floor of the ulcer. The ulcer does not cross the midline or involve the floor of the mouth. It is just approaching the gingival buccal sulcus. Like I think we have mentioned this earlier. You need to only mention it once. The movement of the tongue is normal. There's no deviation or fasciculation seen, right? So you can mention it just once. Probably over here is more appropriate. And most importantly, there's no leukoplakia or erythroplakia in the oral cavity. Now, when you come to palpation, you do it with a gloved finger and you confirm your inspectory findings. So temperature of the ulcer is normal. There's mild tenderness and mild bleeding on touch. And there's a single ulcerative growth of the left lateral border of the tongue, which is size 5 into 4 into 2 centimeters, where 2 centimeters is the thickness, which is irregular in shape and edges are reverted. The lesion is 1 centimeter away from the tip of the tongue and 1 centimeter lateral to the circumvalent papillae. The base of the ulcer is indurated. Induration does not cross the midline. Tip of the tongue, base of the tongue, and floor of the mouth are free on bimanual palpation. There's no satellite nodule seen, and there's no evidence of any other lesion in the oral cavity. The temporomandibular joint is normal, right? There's no obvious swelling seen on inspection or palpation, and skin over the neck appears normal. There's no scars, sinuses, or dilated veins. Indirect laryngoscopy is done and is seen to be normal. Systemic examination is within normal limits. So here you have a 63-year-old male who's a chronic smoker, presents to us with a non-healing painful ulcer or the left lateral border of the tongue with irregular borders, everted edges, and mild bleeding on touch with restricted mouth opening and halitosis without any neck nodes. So this could, based on what we know, this could be a case of CA tongue, left lateral border, clinically T3, N0, M0, right? Now, right off the bat, I need to discuss one thing here when it comes to the inspection and palpation. There is something called depth of invasion and thickness, right? So usually on inspection, we can only appreciate the length and breadth of the lesion. But when it comes to palpation, you can also appreciate the thickness of the lesion, especially if the lesion is pinchable, right? And can be palpated bidigitally. But the thickness is separate from the depth of invasion. What is the depth of invasion? The depth of invasion is actually the distance from the invasion of the base. So we're measuring the degree of invasion past the basement membrane, right? So the distance from the basement membrane to the tip of the invading tumor, right? So that is the depth of invasion. Whereas the thickness includes the depth of invasion as well as the proliferative component. So for a proliferative lesion, the depth of invasion is not equal to the thickness, which will be more. Whereas for an infiltrative lesion, the depth of invasion and the thickness will be relatively the same. So you need to know that difference. Another thing to note here is that depth of invasion cannot be appreciated clinically. It should be, you can get an idea with an MRI, but it is a pathological statement or a pathological finding. So histopathology is the main method through which we can accurately know your depth of invasion, right? So that is also something you need to keep in mind. Now, another thing that you need to know here is the types of lesions, right? So what are the morphological lesions that you can see in an oral cavity case? So you can see an ulcerative lesion, a proliferative lesion, an infiltrative lesion, a verrucous lesion, or combinations of these lesions. And the best prognosis or the most chemoradiosensitive lesion is considered to be a proliferative lesion. Now, another thing they can ask you here is, what are the reasons for examination under anesthesia, right? So examination under anesthesia in an oral cavity head and neck case is especially when you have tumors extending posteriorly. So example, to the base of the tongue or to the vallicula. So these places cannot be examined normally because it is painful for the patient and due to the gag reflex. So these areas can be examined under anesthesia. Also, if the patient is non-cooperative or if the patient you're looking for synchronous or metachronous disease, there also you can do examination under anesthesia. And of course, if you have a neck node and you're looking for an unknown primary, there also you can do examination under anesthesia. So those are the reasons, those are the areas where you do examination under anesthesia, right? Now, in this CA tongue case, what is the significance of involvement of tip of the tongue and base of the tongue? So the base of the tongue is involved. It is difficult to resect the lesion and the lesion might be borderline unresectable, or it will be difficult to resect with preservation of functionality of the tongue. So that is importance of involvement of the posterior 1/3 or base of the tongue. If the tip of the tongue is involved, it becomes difficult. If post resection, the patient might find it difficult to talk, to have proper speech. So that is the practical implication of involvement of tip of the tongue, right? So that's that. Now, based on your clinical findings, right? So you've done your examination. Based on that, what are the conditions or what are the signs that we can elucidate or signs and symptoms that point towards inoperability on your examination history? So this could involve, if you have a fixed nodal mass, right? Or if you have a bulky nodal lesion, if there's difficulty in mouth opening, could point towards an advanced disease. If you have involvement of the oropharynx, the base of the tongue, the vallicula, etc., that could point towards inoperability. If you have, multiple cranial nerve palsies, which could point towards a base of skull invasion, that can also point towards inoperability based on your history and clinical examination. So this is also something that you need to know, right? So this is the questions that are commonly asked in a case of CA tongue. Now, when you write down your examination findings in a case of CA buccal mucosa, I told you that buccal mucosa is the other site that is kept in exams when it comes to an oral cavity cancer, right? So buccal mucosa, you need to describe the lesion both in inspection and palpation, um, you know, in terms of relation to surrounding structures. So buccal mucosa lesion, posteriorly, you look at the distance from the retromolar trigon. Medially, you look at whether the alveolus is involved or the gingivo-lingual sulcus is involved. And laterally, you look at whether the skin is involved. And of course, you also look at whether the upper and lower gingivo-buccal sulcus is also involved. So these structures also need the relation of a buccal mucosa carcinoma, buccal mucosa lesion needs to be described in relation to these structures when it comes to a buccal mucosa case. So that also I thought I could add on because that is also commonly asked, commonly kept in exams, carcinoma of the buccal mucosa, right? Right. Okay. Now, coming to the neck examination, so you need to know the common sites of drainage of an oral cavity case. Usually this is between level 1 to level 3 of the cervical nodes. Okay. Now, you might get skip mets in case of CA tongue. The incidence is around 10 to 15%. And so CA tongue especially has a high propensity to metastasize to level 4 nodes without involvement of the preceding levels. So that's why skip mets are seen 10 to 15% in case of CA tongue. So oral cavity generally is level 1 to 3. CA tongue could be level 1 to 4, especially they have skip mets. And in case of, for example, other sites like a CA lip, it is level 1 and 2 only. Okay, so these are the common levels involved in oral cavity cancers. Now, you need to be aware of head and neck malignancies with a high risk of lymph node involvement, right? So that is mentioned in DaVita. So high risk sites with greater than 30% risk of occult nodal mets in case of a clinically neck negative node. These sites involve nasopharyngeal carcinoma, oropharyngeal carcinoma, especially if it is HPV positive, hypopharynx, including the piriform fossa, and of course, tongue and floor of the mouth, right? So these are some of the sites with a high risk for nodal invasion, right? Okay, so now that we have mentioned all of that, let us now look at something that is also important that can be asked for your exams, right? So we need to know the levels of lymph nodes, levels of cervical nodes. So level 1 is your submental and submandibular levels. So they extend superiorly from the mylohyoid muscle and mandible, inferiorly to the border of the inferior border of the hyoid bone, right? And the level 1A and level 1B are divided by the digastric muscle. Now, level 2 is the upper internal jugular or deep cervical chain. So superiorly extends from the base of the skull and inferiorly to the inferior border of the hyoid bone. Okay, so this is divided based on the internal jugular vein into level 2A and 2B. You also have level 3, which is the middle internal jugular or deep cervical chain, which extends superiorly from the inferior border of the hyoid bone, inferiorly to the inferior border of the cricoid cartilage, right? So that is level 3. Level 4 is the lower internal jugular or deep cervical chain, which extends superiorly from the inferior border of the cricoid cartilage, inferiorly to the level of the clavicle. And level 5 is the posterior triangle, which extends from the meeting point of the sternocleidomastoid and trapezius muscles, and inferiorly it is extends up to the clavicle once again. So these are the levels of cervical nodes, and this is something they can ask you in the exams. Now, coming to a very important thing that you need to know off the top of your head is the staging for oral cavity lesions, right? So you have T1. So I'll start off with the TNM staging quickly. T1 is less than 2 centimeters, less than or equal to 2 centimeters in size with depth of invasion of less than or equal to 5 millimeter. T2 is less than or equal to 2 centimeters size with depth of invasion greater than 5 millimeter and less than or equal to 10 millimeter, or tumor greater than 2 centimeter and less than or equal to 4 centimeter with depth of invasion less than or equal to 10 millimeter. Okay. And T3 is any tumor with depth of invasion greater than 10 millimeter or tumor greater than 4 centimeter with depth of invasion less than or equal to 10 millimeter. Okay. And T4 is divided into T4A and T4B. T4A could be a tumor greater than 4 centimeter with a depth of invasion greater than 10 millimeter, or it could be a tumor that invades through adjacent structures. So this can include the cortical bone of the mandible, the maxilla, into the maxillary sinus, and into the skin of the face. And T4B is very advanced local disease where tumor invades the masticator space, the pterygoid plates, the skull base, and or if it encases the internal carotid artery, right? So this is the TNMs, the T stage that you need to know in depth for an oral cavity lesion. Earlier, there also used to be involvement of T4 was also considered if there's involvement of the extrinsic muscles of the tongue. That is no longer the case. That has been removed. Okay, good. Now coming to the nodal classification clinically, that is also very important. So clinically, N1 disease is if you have a single node, right? A single node which is mobile, right? But if, now N2 is divided into N2A, B, and C. So if you have, so right. So N1 is a single node that is less than 3 centimeters. N2 is divided into N2A, B, and C. N2A is if you have a single node that is greater than 3 centimeters, but less than or equal to 6 centimeters, right? If you have multiple nodes that are greater than 3 centimeters, but less than or equal to 6 centimeters, that is considered to be N2B. And if you have contralateral nodes that are greater than 3 centimeters, but less than or equal to 6 centimeters, that is considered to be N2C. Now, N3B is, N3 is considered if you have extranodal extension or if you have a nodal size that is greater than 6 centimeters, right? So that is N1, N2, and N3. This is also something you need to know. Now, there's a difference between clinical nodal and pathological nodal staging. Pathological nodal staging, N2A, there's an extra point that comes there. So PN2A, there's a difference between clinical. That is, if you have a lesion less than 3 centimeters with extranodal extension, that is also coming under PN2A, which is not seen in the clinical nodal staging, right? So that is the difference between clinical and pathological nodal staging that you need to keep in mind. So just like this, you need to revise the staging of oropharyngeal malignancies, both HPV positive and negative. You need to know the staging of the laryngeal malignancies, especially glottic and hypopharyngeal as well. So all these sites, you should know the staging because head and neck, the staging is a must. That is something that you need to know. Now that we have, right? So here, although we have given a staging of clinically T3, it is incomplete because we do not know the depth of invasion. So that's the fallacy of the AGCC staging, where depth of invasion, although it is ideally defined histopathologically, we might not be able to accurately define it clinically or examination or on imaging even. So that is a fallacy of clinical staging in the AGCC staging. Now, once you have established a possible diagnosis, in this particular case, it clearly looks like a case of CA tongue, clinically T3N0M0. How do you proceed? So like I said, you do the workup of the patient, and workup comes under, right? Workup comes under 3 headings, right? So you have the diagnosis, workup for diagnosis, workup for staging, and workup for treatment. So these are 3 headings under which you need to tell the examiner about how to work up this particular patient. Always divided into these 3 headings, right? So workup for diagnosis and staging involves a biopsy and imaging. Now, question here is, do you do the imaging first or do you do the biopsy first? For smaller lesions, right, you should always do the imaging first. What is the reason for that? Because if you do a biopsy prior to imaging, there might be edema, or there might be a development of hematoma, or there might be a development of reactive lymph nodes that could falsely upstage your disease on imaging. So always do the imaging, especially for, earlier lesions prior to your biopsy. So that is the reason why. So your imaging, what is the imaging of choice? So in this particular case, in a CA tongue case, you would ideally do an MRI head and neck, right? Why do we do MRI head and neck in a CA tongue case? There are many reasons why. So CA tongue is one of the malignancies. You can also do an MRI head and neck in case of a nasopharyngeal malignancy because you need to elucidate various soft tissue involvement, right? So that's why you generally tend to do CA tongue and nasopharyngeal. You tend to do a MRI of the head and neck. Okay, so what are the findings you can elucidate in an MRI? So you can know the extent of the disease, right? And soft tissue involvement. You can know the involvement of floor of mouth, whether the midline is involved. You can get an idea for the depth of invasion, although that is ideally seen on histopathology accurately. You can get an idea for lymph node involvement. You can get an idea for perineural invasion, neurovascular invasion, cranial nerve involvement, and involvement of base of the skull, right? You can get an idea for marrow involvement, especially if the bone has been compromised. You can get an, mostly in CT scans, there might be, if they're fillers or dentures, they can lead to extensive artifacts. Although MRI can also cause artifacts in this scenario, it is much lesser than CT scan. And of course, to plan your reconstruction and surgery, MRI is of great use, right? So MRI head and neck in these settings or in CA tongue, nasopharynx, and also if these indications are required to be met. That's what you do in MRI head and neck. Otherwise, for all the other oral cavity malignancies, you would do a CT of the head and neck, right? So that can also give an basic information for other oral cavity malignancies apart from tongue and nasopharynx, or if there are any other indications for MRI. But most cases, like I said, you would do a CT, head and neck, right? And you would use a technique. This is another thing they can ask you in the exam called a puff cheek technique. So you blow so that these structures can be well drawn out when you do your CT scan, right? So that is how you do your diagnostic workup and local staging. Now, coming to the metastatic staging, in most cases, you would tend to do a CT thorax because lungs are the most common site of metastasis in an oral cavity malignancy. Now, we need to know the importance of ultrasound neck. Ultrasound neck is done when you have to see, when you have to take a fine needle aspiration of the neck nodes. For example, if you have one or two nodes and you're unsure about whether they're involved, you can do an ultrasound guided FNAC of those nodes, right? But in cases with like diffuse nodal disease, that it might not be of much use. But in single or one or two mets, you're doubtful, you can do an ultrasound guided FNAC that can guide you. Now, what is the role of PET-CT in oral cavity malignancies? So PET-CT is done as an upfront diagnostic tool in patients. This is also recommended by the NCCN in patients with N2, N3 disease, in patients with low involvement of nodes, right? So if you have nodes extending below the thyroid nodes, there also you can consider. In T4 disease, also you can consider, right? So if these risk factors are present, there's a greater than 20 to 30% chance of distant mets. So you can do a PET-CT upfront in those cases. The other uses of a PET-CT include, in case of radiation planning, so you can use PET guided contouring of the lesion. You can, if you have an unknown primary, there's a 30% chance of finding the primary. If you have a neck node with unknown primary, 30% chance of finding the primary with a PET-CT. If you have recurrent disease, right? Or if you, it can also be used to assess for residual disease post-radical CTRT in head and neck malignancies. So post-radical CTRT, you would wait till 12 weeks and do a PET-CT. If there's any nodal uptake in that 12-week PET-CT, post-radical CTRT, then you would consider doing a radical neck node dissection, right? So that is the use of PET-CT, post-radical CTRT, to see if there's any viable nodal disease. Okay, so those are the indications of PET-CT in a head and neck malignancy. Now, to complete your staging, you would also do a triple pan endoscopy to see for synchronous lesions, right? So that includes a laryngo and bronchoscopy, nasopharyngoscopy, and a pharyngoesophagoscopy, right? So those are the three scopies you do, which make up your triple pan endoscopy to look out for other synchronous lesions. This is done as a rule for most cases in certain institutes, whereas it's done in select cases in other institutes, right? Now, once you've done your imaging and everything, that's when you proceed to your biopsy, ideally. So biopsy can consist of, incisional biopsy. It could be a punch biopsy, right? Incision is done in case of infiltrative lesion, especially like an infiltrative lesion of the tongue. Punch biopsy is done in proliferative lesions. You can sometimes also, you might need to do an excision biopsy, right? So if patients, you have a lesion that is suspected with a high suspicion of malignancy, where you have done a biopsy, but it comes out to be inflammatory. There's no evidence of malignancy, but you're still suspecting a malignancy. You can consider doing an excision biopsy, especially when your normal biopsy is coming out to be negative for malignancy on repeated samples. So there you can do an excision biopsy to confirm, right? And during the excision biopsy, you can also do a frozen section and convert it, if malignant, to a wide local excision, right? So those are some of the ways you can approach your biopsy. Now, we have done our workup for diagnosis as well as staging. Now, what is the third prong? The third prong of workup is, workup to do your treatment. So number one here is, if the patient has a history of tobacco, you should counsel the patient for de-addiction. Why is that? Because every phase of treatment, from pre-treatment to during treatment to post-treatment, right, is, tobacco intake can harm the efficacy and outcomes with your treatment. So always make sure you send the patient to a de-addiction center, especially if they have a history of tobacco intake, right? So you need to know some of the pharmacological methods and non-pharmacological methods of tobacco cessation. So that includes nicotine replacement therapy. It can be in the form of gums, it can be form of a sticker, it can be in the form of lozenges. Or you also have pharmacological agents such as varenicline, right, which is given at a dose of 300 mg OD, and also bupropion, which is given at a dose of 2 mg, right? And comparing these two agents, varenicline has shown to have higher rates of abstinence from tobacco. So those are some of the pharmacological methods. Now, the non-pharmacological methods include the 5 A's. So ask, advise, assess, assist, and arrange. You need to be prepared with these answers when they ask you what are the methods of tobacco cessation. So workup for treatment, start off with de-addiction counseling and intervention. Second is dental treatment, right? So dental, you would send the patient to a dentist to do grinding, scaling, and removal of jagged teeth. And you'll also apply a fluoride tray. Why do you do this shaping of irregular teeth or removal of jagged teeth? Basically because presence of such teeth can lead to an increased risk of osteoid necrosis with radiation. It can also lead to infections and increased side effects while on treatment, both surgery and radiation. And of course, you apply a fluoride tray because there is high chance for xerostomia, especially with radiation. So that can prevent dental caries and formation of infection. So sending the patient to a dentist, before surgery and before radiation, 2 to 3 weeks before radiation, is very important. Nutritionist is also another important thing, because the tolerance of treatment is, the patient's ability to tolerate treatment is based on their nutritional intake. So send the patient to a nutritionist and create a nutritional plan prior to surgery and prior to RT as well. Speech therapist, right? A lot of these treatments, both surgery and radiations in head and neck malignancies, can impair your speech. So prior to these treatments, you would send the patient to a speech therapist to train them in exercises to preserve their speech, and also to adjust with post-surgical or post-RT interventions that could hamper their speech, right? Then next is swallowing. So swallowing can be affected both with surgery and especially with radiation, especially when the muscles involved in swallowing are irradiated, right? So you would look at a baseline swallowing function of the patient by two techniques. So you have a fiber optic endoscopic evaluation of swallowing, or FEES, or a video fluoroscopic swallowing study, which is VFSS, right? So both these techniques can be used to note down the baseline swallowing efficacy of the patient. Now, before you give your systemic therapy, there are a few other clearances that you need, right? So as a part of workup for management, you do a baseline audiometry, a creat clearance, and if confusion is there, you do a DTPA scan, right, and a cardiology clearance with an echo for your cisplatin-based treatment, right, which is commonly used concurrently with radiation. So baseline audiometry, creat clearance, and cardiology. Now, other tests that you can do is DPD. If you're giving especially neoadjuvant treatment with DPF regimen, which contains 5FU, you can do a DPD testing. And if you're giving, immunotherapy, as for example, as part of the Keynote 689 protocol, then also you can do a baseline TFT and serum cortisol, right? So all these complete your workup for treatment. And if you can say all these things, the examiner will be thoroughly impressed. And I think you can just note down all these points and say it verbatim for your exam, right? So two other points I like to discuss that are commonly asked is, what is prehabilitation and what is the ERAS protocol? So prehabilitation is a protective strategy to optimize physical and mental health to improve outcomes and recovery, prior to surgery. So to enhance those outcomes and recovery, you do a bunch of steps to prehabilitate the patient. And we have described that as part of workup for management, right? So all these things that we discussed earlier, they involve forms of prehabilitation. Now, what is the ERAS protocol? So it is enhanced recovery after surgery protocol, and it is done, throughout treatment. So pre-surgery, during surgery, and post-surgery, you would implement the ERAS protocol, and you would intervene to ensure optimal recovery and outcomes. So all these techniques that we discuss come under the errors protocol, right? So you need to be aware of that. That is something that they can ask you in your exams. Now, we have now completed the workup. All these points that are discussed are very important, and they can't ask you anything beyond this. I think this covers most of the points that are commonly asked for an oral cavity malignancy, right? So now coming to the management protocol, always ensure that when the examiner asks you what is the management of this malignancy, say I will take this case based on the workup and discuss this in a multidisciplinary tumor board consisting of surgical, radiation, as well as other adjunct healthcare professionals. So that is something that you need to say upfront, right? Now, for this particular case, what would be the treatment of choice? So ideally, you do a wide local excision, right, of the tongue lesion, and you'll also do a lymph node dissection, right? For this case, you do an extended supra-omohyoid lymph node dissection because it is a tongue case that can spread up to level 4. So omohyoid dissection involves levels 1 to 4, and that is ideal for a tongue case, right? So wide local excision with extended supra-omohyoid neck dissection. So we'll get into the different types of neck dissection later on. Following that, in this particular case, post-surgery, if there are various indications to radiation, you would like to give adjuvant radiation, especially because it's a clinical T3 disease. And if needed, based on the histopathology reports, you can also add concurrent chemotherapy to the radiation, right? Good. So that is the treatment protocol for this particular case. Now, let's get into the surgical aspect, the questions they can ask you regarding surgery. So wide local excision is commonly done for tongue lesion, or it can extend to partial or total glossectomy, depending on the amount of tongue involved. And the most common used flap for reconstruction, you need to just remember 3 flaps to say in the exam. So radial forearm flap, an anterolateral thigh flap, a pectoralis major muscle flap, or a fibular free flap. So these are some of the flaps used for reconstruction. And when is reconstruction done in a tongue lesion? If more than 30% or 1/3 of the tongue is removed, right? So that's where you do your reconstruction. Now, what are the indications of mandible resection in an oral cavity case? So if the lesion is abutting the mandible, you need only strip the periosteum of the mandible. If it is adherent to the mandible, you do a marginal mandibulectomy. And if it is invading the mandible, then you do a segmental mandibulectomy. Another question that can be asked here is, what is commando operation? So commando operation is when you do a wide local excision, you combine it with a segmental mandibulectomy, and you also do a neck node dissection, right? So all 3 components make up the term commando operation. Now, another question that can be asked here is, what is the ideal margin for wide local excision? The cutoff is greater than 5 millimeters, right? So anything less than that is considered to be close margins. Now, coming to the lymph node dissection, the question they can ask you is there any evidence of omitting lymph node dissection in an oral cavity malignancy? So there's been a Tata trial done by Anil D. Cruz et al., which shows that in T1, T2, lateralized lesion, when they compared elective nodal dissection versus wait and watch approach, there was an improvement in survival outcomes with elective neck node dissection. So for all cases, you should do elective neck node dissection. Another question they can ask you here is there any role for sentinel lymph node biopsy? The answer is that there is not much role currently. It is not standard of care because the high false negative rates, okay? But it has been attempted in T1, T2, N0, well lateralized lesions not crossing the midline, although not successfully due to the high false negative rates. Now, let's get into the type of lymph node dissections, a very favorite question that's asked. You might be wondering, although this is a medical oncology exam, as an oncologist, you should be aware of all the 3 prongs of treatment, that is surgery, radiation, as well as systemic therapy, right? So as an advisor, as a member of the tumor board, you need to be aware of the basics of all 3. That is what they're going to ask you in the exam. So that is why I'm stressing on all these important points. So types of lymph node dissection involve radical nodal dissection, which is level 1 to 5, modified radical nodal dissection, which is level 1 to 5, but with preservation of structures. So MRND type 1 is the spinal accessory nerve is preserved. MRND type 2, the internal jugular vein and spinal accessory nerve is preserved. And MRND type 3, the sternocleidomastoid, IGV, and spinal accessory nerve, all 3 structures are preserved. Now, other types include the supra-omohyoid neck dissection, which is level 1 to 3, which is commonly done in oral cavity cases, because we know that it's spread commonly to level 1 to 3. And you have extended supraomohyoid neck dissection, which is usually done in CA tongue because you remove level 1 to 4. And we know that those are the scenarios in which you tend to get skip beds, right? So CA tongue, extended supraomohyoid neck dissection. Then lateral neck dissection of level 2 to 4 is done usually in your oropharyngeal, hypopharyngeal, and laryngeal malignancies, right? If resection is done in these cases. So those are the different types of neck dissection that we tend to encounter. Now, right. So now let us get into the nitty-gritty of radiation, right? So what are the indications of radiation in an oral cavity case? They'll definitely ask you, you need to be prepared with the answers. So the indications include T3, T4 disease, LVI, PNI, multiple nodal involvement, worst pattern of invasion 5. So that is if there's a tumor cell and there's greater than 1 millimeter separation with another deposit of tumor cells that is seen, right? So primary tumor separated by greater than 1 millimeter with another deposit of tumor cells or islets of tumor cells, right? So that is called worst pattern of invasion if there's a distance is greater than 1 millimeter. Okay, so worst pattern of invasion 5, that is also an indication for RT. And of course, so these are all T3, T4, LVI, PNI, worst pattern of invasion 5, presence of multiple nodes. These are all indications for, they are high risk indications for RT. Now, they are very high risk indications for RT. Those include extracapsular extension as well as positive margins. So those are the indications for radiation. Now, what are the indications for uh, what are the indications for concurrent chemotherapy with adjuvant RT, right? So outline the indications for adjuvant RT. The indications for adjuvant concurrent chemotherapy in a case of CA oral cavity include extracapsular extension and margin positive involvement. So that is based on the Bernier and Cooper et al., the EORTC and RTOG trial, which showed increase in survival outcomes with addition of concurrent chemotherapy to adjuvant RT, right? So that is something that you need to know. The indications of adjuvant RT, indications of adjuvant chemotherapy. Now, just to complete adjuvant radiation, what is the concept of accelerated repopulation? So in all head and neck malignancies, you get an accelerated growth of tumor on around the 4th week after starting radiation, right? Due to the proliferation of resistant clones which lie dormant, they are activated by radiation and they proliferate rapidly post around the 4th week or so. So this is something that causes, ineffective management of the tumor, especially with radiation. So it is of paramount importance to start the adjuvant radiation early after surgery, that is within 4 weeks. And also, once you've started radiation, do not stop it for any other cause, because the dose that is, once again, the dose here in adjuvant setting, adjuvant RT, is 60 gray in 30 fractions. That is 60 gray delivered over 6 weeks, 5 fractions per week. That is from Monday to Friday, right? So that dose is designed in the adjuvant setting to tackle accelerated repopulation as well. So if we have gaps during RT, or if you start RT late after surgery, that is more than 4 weeks later, then that dose might not be sufficient to account for accelerated repopulation, which is seen in all oral cavity malignancies or head and neck carcinomas, right? So that's the concept of accelerated repopulation. Now, there's an advancement here that the examiner might ask you. That is the Keynote 689, which is currently just recently was FDA approved. So in an oral cavity case, you can also consider, right? So Keynote 689 looked at locally advanced oral cavity disease. So that's stage 3 and stage 4A, right? That underwent resection. So these patients were subjected to 2 cycles of neoadjuvant pembrolizumab, 200 mg, 3 weekly. Following that, they were taken up for surgery and they were given adjuvant RT or concurrent chemotherapy with RT if indicated. And along with that, post-surgery, they were also started on pembrolizumab, which is given for a total of 15 adjuvant cycles as well. So that is a Keynote 689 protocol. And in patients with a combined positive CPS score of greater than or equal to 1, it showed an EFS absolute benefit of around 14%. So that has been FDA approved, and that is also the current standard of care, although many of our patients might not be able to afford pembrolizumab, right? So that is something that you need to look at. Now, what are the other approaches that you can use in a case of oral cavity carcinoma? This is the basic outline. You do surgery primarily, And if required, you give RT or along plus or minus concurrent chemotherapy. The current standard of care has changed. It is now neoadjuvant pembrolizumab with surgery followed by CTRT plus or minus CTRT with adjuvant pembrolizumab up to 15 cycles. So that is the current standard of care based on the Keynote 689 protocol. So we talked about how we normally manage oral cavity cancers. What about other approaches? So sometimes if the patient is not fit for surgery, the patient denies surgery, or the disease is locally advanced and is not amenable to surgery, there you can consider giving radical CTRT at a dose of 70 gray in 35 fractions with concurrent chemotherapy, right? So radical CTRT can be given in those patients. Then, of course, you can give electron beam therapy in certain subsites radically, like the lip, in which resection might lead to extensive morbidity. So there you can treat with electron beam therapy radically. Also, you have brachytherapy. So what are the indications for brachytherapy? This include easily accessible oral cavity lesions, especially at the floor of mouth, the buccal mucosa, etc., that are T1 lesions or select case of T2 lesions. So there you can give brachytherapy, and brachytherapy is given either with LDR or HDR. So high dose rate, that is at a dose of greater than 12 gray per hour, or it is given at low dose rate, that is at a dose rate of less than 2 gray per hour. So high dose rate, the dose is 48 gray in 12 fractions, which is given as 4 gray twice daily into 6 days, right? So you can just note down if they ask you. And LDR is given at 65 to 70 gray over 6 to 7 days, right? And for what are the radioactive nucleotides used for HDR and LDR? So HDR, it is iridium 192, and for LDR, it is iodine 125 and palladium 103. So these are some of the things they can ask you regarding the indications for brachytherapy. And of course, although this is not standard of care, in some patients, you can consider giving neoadjuvant chemotherapy, especially patients who are borderline operable, who have, fixed bulky nodes, which might not, to surgically resect them easily, you can consider giving neoadjuvant chemotherapy. Although this is not a standard of care in CA oral cavity cases. So those are some of the other alternative approaches for oral cavity cases. Now, let's get into the other sites, right? So for oropharynx, hypopharynx, and larynx, right? This is how you go about management. For a T1, T2 lesion, you need only give RT alone. Radiation alone, radical radiation alone is enough. So radical radiation in a T1, T2 lesion for oropharyngeal, hypopharyngeal, and laryngeal cases involves 70 gray in 35 fractions, right? 66 to 70 gray in 35 fractions, right? Delivered using conventional radiotherapy or other forms of fractionation. We'll discuss that later. So radiation alone is enough, or you can do surgical treatment with transoral robotic surgery or translaser surgery combined with a lymph node neck dissection. So these are the options for T1, T2. Why don't we jump towards surgery for, your oropharyngeal, hypopharyngeal, and laryngeal cases? Because surgery is extensively morbid and can decrease functionality. So unlike oral cavity, surgery is only used in select cases. So T1, T2, give RT alone if possible. Less minimally invasive surgery techniques like TORS and TLS can be used, but mainly it's RT alone, right? So because of the extensive morbidity. So once again, because of the extensive morbidity for lesions that are T3 and more, or node positive, you give for these three sites, oropharyngeal, hypopharyngeal, larynx, you give for these advanced lesions, you give radical chemoradiation. So radical chemoradiation consists of 70 gray in 35 fractions, usually given with intensity modulated radiotherapy, which prevents toxicity to surrounding structures, and you give it with concurrent cisplatin, right? That's the standard of care. So for T3 and above or node positive disease in oropharyngeal, larynx, and hypopharyngeal cases, you give concurrent CTRT. Now, what is the role of surgery in these advanced cases in these sites? So we have discussed the role of minimally invasive surgery for early disease, but in advanced cases in these sites, you do surgery if there's already loss of function, right? So if the swallowing is affected, if the larynx is, properly fixed, if the thyroid cartilage is, invaded and destroyed, in those cases, function cannot be preserved with CTRT. So there you do a surgery and then you give adjuvant RT because it's a locally advanced case, right? So that is the treatment if the function is lost, for example, thyroid cartilage invasion, fixation of the larynx, etc. So that's where you do surgery in these sites. I hope you understood that point and the basic paradigm of treatment for based on the how advanced the tumor is in oropharyngeal, hyperpharyngeal, laryngeal cases. Okay, so it's different from oral cavity. So another thing that we need to talk about here is fractionation in radiation, right? So what are the types of fractionation? So you have, this can be asked to you in the exam. So you have conventional fractionation, which is 1.8 to 2 gray per fraction given Monday to Friday with 2 days off. Then you also have altered fractionations. So these include hyperfractionation. So hyperfractionation is given in tumors that are radiosensitive. What you do here is that you divide the dose into multiple fractions per day. Instead of single fraction per day, you give multiple fractions per day. So that multiple fractions per day in a radiosensitive tumor prevents the repair of sublethal damage that can repair damage to tumor cells, right? So you prevent sublethal damage by injecting multiple fractions, although the dose per fraction is smaller, but they're given more frequently to prevent the repair of sublethal damage in a radiosensitive tumor. For example, a head and neck malignancy, head and neck squamous cell carcinoma. So hyperfractionation is a technique that's used. Another technique is accelerated fractionation. So accelerated fractionation is where radiation is given over a shorter period of time. An example of acceleration would be treating from Monday to Saturday instead of Monday to Friday, so it can cut down the total radiation time. So that takes care of what we discussed earlier, accelerated repopulation, which starts around 4 weeks, right? So accelerated fractionation is another technique. Now, you also have hypofractionated radiotherapy, where you give a dose greater than 2 to 2.2 gray per fraction. So a higher dose per fraction is given. So the advantage here is that you can decrease the late toxicity when you give a higher, you can decrease the Right. So you can basically decrease the acute toxicity. You can decrease the treatment time by giving a higher dose per fractionation. The disadvantage is there'll be more late toxicity with higher dose per fractionation. Now, whereas hyperfractionation given in head and neck, they can ask you this. It's usually given in T1, T2 larynx, and also it can be tried in oral cavity malignancies. That is 55 gray in 20 fractions has also been tried, and it is an alternative treatment method, right? So those are the forms of fractionation. I hope you got why they're used and what it means when you talk about these forms of fractionation. I hope you're able to define them now. Now, coming to, let's now go to the next topic, which is concurrent chemotherapy, right? Now, we spoke about concurrent chemotherapy. Let us look at how we administer concurrent chemotherapy, right? So concurrent chemotherapy is most commonly given in the form of cisplatin, right? Cisplatin is a platinum agent. And what is the dose? It is given in two dose forms. The original dose is 100 milligram per meter square, day 1, 22, and 43, either with concurrently given with adjuvant radiation in oral cavity cases or with radical radiation, right? So 100 milligram per meter square, day 1, 22, and 43. So that's the 3-weekly regimen. That was the standard of care usually used in Western countries. Now in Asian countries, we have developed a weekly protocol. So based on the CONCERT trial, based on the JCOG trial, and also the Norono et al. Phase 3 trial, they've shown that weekly cisplatin at 40 milligram per meter square is also efficacious. Now it is equivalent to 100 milligram per meter square 3 weekly if you give a cumulative dose of greater than 200 milligram per meter square. So that is also important. Weekly 40 milligram per meter square with a cumulative dose greater than 200 milligram per meter square is equivalent to 100 milligram per meter square 3 weekly, right? So that is something that you need to know. These are the two dosage forms, 3 weekly and weekly. If you give a lower dose weekly, that is considered to be inferior to the 3 weekly regimen. So always give 40 milligram per meter square with a cumulative greater than 200 milligram per meter square. So that is also important when you're giving weekly to make it equivalent to 3 weekly. So weekly is considered to be more tolerable, and that's why we use it in our patients. Now, what is the mechanism of action of cisplatin, right? Cisplatin causes intra-strand linkages between guanine and guanine groups and leads to DNA breakage, right? And that can combine with the effect that radiation has on the DNA strands, and it acts synergistically. So both act on the DNA and cause DNA damage and can enhance each other's effects. So there's a synergy there, right? Now, what are the precautions that you take with cisplatin, or how do we prescribe a dose of cisplatin? So I'll just give you the prescription that the examiner can ask you for a 100 milligram per meter square, 3 weekly cisplatin regimen. So when you're giving cisplatin, you give level 4 anti-emesis cover. So you give emeset, you give ondansetron, you give an NK1 antagonist, either as fosaprepitant or aprepitant, fosaprepitant 150 milligram in 30 ml NS or in 100 ml NS over 30 minutes, or aprepitant 125 milligram day 1, 80 milligram day 2 and day 3, right? And also you can add olanzapine from day 1 onwards, 5 mg. So you give cisplatin as follows. You give 100 ml of sorry, 2 pints of 500 ml NS or a single bottle of 1000 ml NS. You give that over 2 to 3 hours. And following that, you give mannitol. So mannitol is given either as 10% 400 ml or 20% 200 ml. So you give that over 30 minutes. Next, you give your cisplatin after ensuring that you have a urine output of greater than 100 ml per hour. So cisplatin is given in 500 ml NS over 1 hour at 100 milligram per meter square. Following that, you give 2 more pints of NS or a 1000 ml bottle of NS, and in that post cisplatin hydration, you add 2 ampules of magnesium sulfate and 1 to 2 ampules of KCl as well, because these electrolytes can be decreased when you administer cisplatin. So following that, you give your post chemotherapy antiemetic prophylaxis, either in the form of dexamethasone and olanzapine for 3 days, or in some institutes you give MSZ, dexa, and pan, right? So it depends. So you, based on the institute, you can say the post chemotherapy antiemetic protocol. So that's how you administer cisplatin, right? 1000 ml NS, mannitol, cisplatin over 1 hour after ensuring adequate diuresis, and adjuvant 1000 ml NS with magnesium and potassium chloride supplementation. Now, when you give the weekly protocol, you need not give that much hydration. So 500 ml of NS and before and after cisplatin is adequate, right? And so lesser hydration is only required for 40 milligram per meter square weekly cisplatin regimen. So that is also another point that you need to keep in mind. Although in some institutes they still give 1 liter before and after, even for weekly, but the standard is just 500 ml is enough before and after cisplatin. So I hope you got that. Now, the side effects, mainly you have myelosuppression, you have nephropathy, you have ototoxicity, you have neurotoxicity, right? So all these side effects can be seen, especially nephrotoxicities, you need to monitor that. So that can present as acute kidney injury with raised creatinine that is non-oliguric, right? And you can get tubular cell casts, and also you can get, no proteinuria or hematuria is commonly seen. So no proteinuria, no hematuria, and also tubular cellular casts are seen in the urine routine examination. So those are things that you need to look for. And also, apart from that, you can also get renal tubular acidosis as well. And it's also associated with hypokalemia, hypomagnesemia, hypophosphatemia, and hypocalcemia. So all the different electrolytes can be decreased in case of cisplatin nephrotoxicity. And you need to watch it for magnesium, because if magnesium decreases, the other electrolytes will automatically decrease because their absorption is dependent on the magnesium levels. So all these things need to be looked at. You need to look into when you give your cisplatin. These are the precautions that you have to keep in mind. Right, now cisplatin, I told you the evidence for concurrent cisplatin in adjuvant treatment, right? The Bernier and Cooper et al. RTOG and EORTC trials, where it says that you can give concurrent cisplatin with adjuvant RT if there's extracapsular extension or involvement of margins. Now, for radical RT, concurrent cisplatin, the evidence was established by the MAC-NC meta-analysis. What did it show? It showed a 5-year benefit of adding concurrent cisplatin to radical RT of 6.5%, right? And it showed a benefit over giving neoadjuvant chemotherapy or giving adjuvant chemotherapy. So best way to give chemotherapy with relation to radical radiation is concurrent chemotherapy in the form of cisplatin. It also found that platinum-based regimens were most efficacious, and cisplatin-based monotherapy was equally efficacious to cisplatin coupled with other agents such as 5-FU. So it is equally efficacious. That is why we give single-agent cisplatin. It also found that for patients greater than 70 years of age, there might not be a benefit. In fact, there might be a detriment to adding concurrent cisplatin with radical radiation. It also found that T1 and T2 lesions probably had no benefit from, adding concurrent cisplatin to radical radiation. So these are the points that were discovered in the McKenzie meta-analysis. What is another agent that can be given with cisplatin? So example, if you have peripheral neuropathy, if you have cardiac failure, especially NYHA 3 or more, if you have sensory neural hearing loss, if you have a creat clearance less than 50 to 60, there you cannot give cisplatin. It becomes difficult. So there you can give cetuximab, right? So cetuximab was initially bought in based on the Bonner trial, which looked at RT versus RT plus cetuximab, which showed an OS benefit for addition of cetuximab. Cetuximab is an anti-EGFR inhibitor. It is given initially at a loading dose. So it is given prior to radical RT. So you give it prior to radical RT, 400 milligram per meter square. So 1 week prior, you give cetuximab 400 milligram per meter square in 500 ml NS over 2 hours. Following that, you give weekly during RT, 250 milligram per meter square of cetuximab. Unlike the initial dose, which is given at 2 hours, you give the subsequent doses, if tolerated, at 1 hour. Now, what are the side effects here? So it can cause severe skin toxicity, especially in the form of pruritus and acneiform rash. It can also cause diarrhea, nausea, and vomiting, right? And apart from that, it can also cause hypomagnesemia and hypokalemia. So those are alkaline things, deficiencies that you need to look out for with cetuximab. Apart from this, another toxicity here is it can cause severe hypersensitivity reactions. That is why you administer the initial dose over 2 hours, the loading dose of 400 milligram per meter square, or 2 hours, and subsequent doses over 1 hour because of hypersensitivity reactions, right? So always give pre-medication with AVIL before giving cetuximab, and always monitor the patient for 1 hour post cetuximab infusion, especially the first infusion, to look for hypersensitivity reactions, right? So these are the side effects of cetuximab. Now, when you compare cetuximab to cisplatin, what does the data show? It is inferior. So we have the RTOG 1016 trial. You have the you have the RTOG 1016 trial. You have the RTScan trial, and you have the relevance trial. All three of which show that cetuximab might be slightly inferior in terms of outcomes to cisplatin, right? So based on that, cisplatin is the treatment of choice. If there are contraindications, you give cetuximab. What are some of the other agents? So this is also commonly asked. What are some of the other agents you can give concurrently with RT? So docetaxel, 15 milligram per meter square weekly can be given. That is based on a Tata trial. That is another option. And in certain countries, you can, including India, there's another anti-EGFR agent. You can mention this last, because the evidence is not so robust. There's another agent called nimotuzumab, which can be given. Nimotuzumab, which can be given 200 milligram per meter square weekly. So that is another agent, although the evidence is not so robust. So mention it at the end for the concurrent agents that you can give with RT, right? So now we come to the question. What are the indications for neoadjuvant chemotherapy when it comes to the context of CTRT? So we know that CTRT is the standard of care for when you give for various indications in head and neck malignancy, right? Radical chemoradiation, right? Except for oral cavity malignancies where surgery is preferred, followed by adjuvant RT or chemotherapy if required. For all the other indications, you prefer radical CTRT to preserve function and to prevent morbidity, like I mentioned before. So what are the indications of adding NECT onto CTRT? The answer is that currently, based on the trial data that we have 5 trials, which include the TTC trial, the Paradigm trial, the DECIDE trial, the GSTTC trial, and the GORTEC trial. So based on these 5 trials, the evidence points against using NECT on top of CTRT, right? Except for the GSTTC trial, all these trials were negative for the outcome improvement with neoadjuvant chemotherapy. So it is not a current standard of care. It can be used in certain settings. So what are those particular settings? So you can use it if the patient is severely symptomatic and you're awaiting RT planning. That is an indication. You can use it if you are considering, preservation of organ function. So if there's extensive lesion and you cannot irradiate such an extensive lesion, the field size will increase. You can consider NACT to decrease the size of that lesion, right? So that is also an indication. Also, you can consider doing it in cases where the surgery is planned, for example, oral cavity case, but it is borderline resectable. So, tongue or buccal mucosa lesion extending posteriorly, or fixed or bulky nodes. There also you can consider adding NACT prior. So that is another role for NACT. And you can also, of course, it is a standard of care. Unlike the other head and neck sites, it is a standard of care in nasopharyngeal malignancies where you give NACT followed by CTRT, right? So those are the indications of NACT on top of CTRT. And it is not a standard of care, but it can be tried in these various settings because there is no survival outcome benefit, right? Another setting where you can use it is if you have N2, N3 lower neck nodes, which have a higher chance for metastatic disease. So in those sites, there might be a decrease in distant Mets, the occurrence of distant Mets, if you consider giving NACT. So that is another rough indication, but currently it is not a standard of care, can be used in particular settings. So that is your answer for NACT. So what is the regimen of choice when you're giving NACT, right? You would give the TPF regimen, which consists of 75 milligram per meter square of docetaxel, 75 milligram per meter square of cisplatin, and 750 milligram per meter square 5-FU given as a 24-hour infusion into 4 days, right? You also have the PF regimen, which is cisplatin 100 milligram per meter square and 5-FU 1000 milligram per meter square for 4 days, given as a 24-hour infusion each day. So those are some of the neoadjuvant treatments that can be used on CTRT in only in particular settings. You should not give neoadjuvant chemotherapy with CTRT in all settings. I'll give you the primary reason why. Because when you give neoadjuvant chemotherapy, it can lead to accelerated repopulation and it can decrease the efficacy of subsequent radiation. So in your practice, always remember, don't jump towards NACT on top of CTRT. Refer the patient unless there's specific indications for directly for CTRT, right? So always remember that. Now, HPV positive oropharyngeal malignancies. Let me just mention that. This is another thing that can be asked you. HPV positive oropharyngeal malignancies, they tend to occur in younger patients. There's a less involvement of cigarette smoking. There's a high risk prone behavior in terms of sexual activity, right? Especially oral sex. And also it is seen in Western countries in a younger age. The tumors, they tend to present with larger neck mass and smaller primaries. And there have been various de-escalation strategies for HPV positive oropharyngeal malignancies, right? So one thing I'd like to mention is the workup is done by looking at IHC for P16 and also with an IHC for P16 should stain with nuclear and cytoplasmic uptake more than 70%. So that is when it's considered to be positive. You can also do DNA PCR for HPV as well. So once you detect it, is there a treatment difference? There have been various strategies like reducing the radiation dose, giving neoadjuvant chemotherapy to reduce the radiation dose, using minimally invasive surgical techniques combined with EBRT if required. So all these strategies have been tried, but currently the treatment strategy remains the same as HPV negative oropharyngeal malignancies. So treatment has not changed, although various de-escalation strategies have been tried. That is something you need to remember. Now, moving on, let us wind up our head and neck malignancy oral cavity carcinoma talk case presentation with a very important topic that is rehabilitation, right? So the acute as well as late side effects of treating for head and neck or oral cavity malignancies. This is something that they will ask you. So acute effects include dermatitis, which can occur 10 to 14 days during radiation, xerostomia, which can occur, with radiation, especially when the salivary glands are irradiated. You can prevent it using IMRT. Also, if you develop xerostomia, you can use gustatory stimulants like xylitolol. You can use salivary substitutes, or you can use stimulants such as pilocarpine and cevimeline. Other side effects include mucositis, which is seen 2 to 3 weeks after start of RT. You can use various benzdiazepine, oral mouthwashes, soda bicarbonate, oral mouthwash, etc. Right? And you can also use pain medication as well as mucin gel or sucralfate O. So all this can be used when you see mucositis during radiation. Also, you can get oral infections. You can see fatigue on RT, and also you can see pain due to RT, right? So all these things are seen, and I've told you the preventive methods as well. What are the late effects? So if the neck is extensively irradiated, you can get external lymph edema or fibrosis, right? So this depends on the RT dose to the neck. It depends on what technique was used. So IMRT might have less lymphedema and fibrosis as compared to conventional radiotherapy. So when you get that, what you need to do is you need to do exercises and a complete decongestive therapy, which consists of manual lymph drainage, use of compression garments and pads, skincare, and basic face, neck, and oral cavity exercises. So doing that, you can manage your lymphedema. Now, you can also get dysphagia due to radiation to the muscles that affect swallowing, right? And you can do baseline evaluation of swallowing with FES and VFSS, as we discussed earlier. So once you get difficulty in swallowing, right, you can do various maneuvers, physiotherapy maneuvers like Mendelssohn maneuver, and also you can do postural assist, which can help you swallow. Now, another toxicity that is seen is osteoradionecrosis, especially if you do dental procedures post-radiation, right? So in that case, avoid dental procedures post-radiation. If you get osteoradionecrosis, the management includes antibiotics, dental care, debridement, in surgical intervention in the form of debridement, hyperbaric oxygen treatment, pentoxifillin plus vitamin E, etc. So another toxicity you can see is voice dysfunction, especially with surgery involving the larynx. For example, if you do a laryngopharyngectomy in a patient with a fixed larynx, right, where function is already lost, voice dysfunction is seen. So there you can use various therapies such as esophageal speech. You can use prosthetic devices like the Bloom Singer prosthesis, which consists of a tracheoesophageal fistula, or you can use an electrical larynx, right? So that's how you manage voice dysfunction. Then you can get sensorineural hearing loss, especially if you radiate the inner ear, or if you're giving cisplatin, right? With a patient with high risk features such as renal dysfunction, you can get sensorineural hearing loss. And apart from this, you can get trismus, you can get shoulder pain, you can get cervical dystonia. All these things can be seen with radiation. You should always advise the patient to do neck exercises during and after radiation to prevent this from happening. So those are some of the acute as well as chronic side effects of treatment in head and neck, especially oral cavity malignancies that you tend to see. Now, coming to follow-up. Follow-up consists of physical examination and scopies. Imaging is not commonly done. You do physical examination scopies. Initially, do it 3 monthly for 2 years. Then the third to fifth year, do it 6 monthly, and then annually, right? So usually you do not do imaging. An indication for imaging, as I mentioned earlier, is PET-CT done post-radical CTRT to evaluate whether there's any viable neck nodes at 12 weeks. So that is one indication where do imaging post-radical CTRT to evaluate the neck nodes at 12 weeks, right? If there's PET uptake in the nodes, you might have to proceed with a modified radical neck dissection or any other forms of neck dissection. So let me also talk here about recurrence, right? So once the disease has recurred, you might consider doing a re-RT, or if you have done radiation before, you might consider doing surgery. For patients who are unresectable on recurrence or patients who have metastatic disease, what is the management? So the management here is currently the standard of care is Keynote 048 trial. That is chemotherapy in the form of cisplatin, 5FU, and pembrolizumab, right? So in this Keynote 048 trial, they compared pembrolizumab alone with cisplatin 5FU plus pembrolizumab versus cisplatin 5FU plus cetuximab, which is the extreme trial, which is the prior standard of care. So what they found is that pembrolizumab alone and cisplatin plus pembrolizumab had better outcomes in form of progression-free survival and overall survival, right? So for pembrolizumab alone, it was seen that improves outcomes over extreme trial regimen, that is cisplatin 5FU and cetuximab, was seen in patients with CPS score greater than or equal to 1. And for chemotherapy plus pembrolizumab, the advantage in survival outcomes or extreme trial protocol was seen in patients regardless of CPS score. So pembro alone, CPS greater than 1, pembrolizumab plus chemotherapy, regardless of CPS score. So immune checkpoint inhibitors have become the standard of care. First slide. If they cannot afford ICIs, you can still give the extreme trial protocol of cisplatin, 5FU, and cetuximab. Another thing to note here is that sometimes in our settings, we don't give 5FU, we give paclitaxel. You can still incorporate ICS with a cis-pacli regimen as well. That is commonly done in our setting to prevent the time constraints of giving 24-hour 5FU infusion. Now, another regimen that you can use post-progression is you can combine taxanes with your anti-EGFR regimen if you're given ICI in the first-line setting. And in the Indian setting, we also have metronomic chemotherapy. So metronomic chemotherapy in the form of methotrexate, either given 9 milligram per meter square or 50 milligrams, plus erlotinib 150 mg OD and celecoxib 200 mg BD. And currently, based on our Tata trial, we have low-dose nivolumab that can be added to this 20 mg OD 3 weekly. So that has shown OS benefit over giving metronomic chemotherapy alone. So adding low-dose nivolumab can improve survival outcomes with metronomic chemotherapy. So that is also another option, especially for a patient that has progressed, post chemotherapy plus immune checkpoint inhibitors, or a patient who has progressed on your regular chemotherapy. So those are the management protocols. You can also consider giving single-agent afatinib for patients of squamous cell carcinoma who progress, post chemotherapy and immune checkpoint inhibitor or anti-EGFR treatment. So that's management of advanced head and neck malignancy or recurrent head and neck malignancy that's not amenable to resection or re-radiation, right? So that is also something that you need to know. I think that brings us to the end of our discussion. I hope that you've understood the history, the examination, and the workup, as well as the treatment of head and neck, especially oral cavity malignancies. And I think we have covered all the points that will keep you in good stead for these upcoming practical exams. Wish you all the best. Thank you very much. I'll be signing out. Thank you.